Okay, I'm here to talk about next to the family, probably the most important of the workers in the home care system, and that is the direct care workforce. I did want to start by saying that when they asked me to do this, I tried to figure out whether we were talking about home health care, home and community-based services, personal care. I've been in this town on and off now for 40 years, and I've been through these things now at least 3 or 4 times, and we've revisited a million times these definitions of what this is and what that isn't. So I've actually decided that I'm talking about all of this because these workers are actually in all of these different parts of the sector. I do think, however, that it is really important for people to understand what part of the sector we are talking about. This morning, we primarily had a discussion from the consumer perspective of primarily a hospice program. We've also had discussion of Medicare home health, the traditional home health program. We've had the house calls program. We have more traditional home and community-based programs. I'm assuming Henry is going to talk more about consumer direction. That is all within the rubric of home care. And I think it's important at some point to not keep using these terms synonymously. First of all, because it's not just a semantic issue. It actually ends up in the numbers. And we have a lot of numbers right now that are all mixed up. I think Tricia was saying this morning, a lot of times you'll look at long-term care numbers and it's got all the Medicare, SNF, and home health in it. Medicare home health is not a long-term services and supports benefit. It is a post-acute and even a primary care now benefit as well. So we have to understand these differences if we're ever going to get anywhere. And particularly as we're talking about these new models, because it gets even more confusing. And then for the direct care worker, who is next to the family the most important member, and it subsumes really at least 3 categories of home health aide, home care aide, personal care attendant, and hospice aide. And then within that, you've got a lot of different categories. Homemaker chore is really not necessarily in home care. It can be in home care. People who actually just come in to do housekeeping and companion services. But typically when we're talking about the home care population, we're talking primarily about the home care aide and the personal care attendant. These are the folks who are actually doing most of the hands-on functional assistance. So what are the responsibilities of these folks? They are primarily doing most of the personal care and hands-on activities of daily living in all of these different kinds of subsectors of home care. They also can assist with instrumental activities like housekeeping, meal preparation, and in some cases where the aides are trained, they're actually doing medication management. More importantly than all of that, however, is that they are really the eyes and ears of the system. Next to the family member, and where there is no family member, and by the way, I think it's really important that while we have acknowledged the family caregiver, we have never talked about what happens in home care when there isn't a family member. Every single one of the examples that were talked about today had a family caregiver involved. There are a lot of folks who don't have any and gone down the road because of increased childlessness and our divorce rate, we're actually going to see a decrease in family caregiving over the next 25 years. So we actually need to be thinking about people who don't have family caregivers. So they are the eyes and ears of the system. They also are very much engaged in the emotional support. Of all of the people in this team, they are typically the folks who have the one-to-one relationship with an elder or a younger person with disabilities. And for better or for worse, they are often the liaison with family caregivers. And there are good relationships and there are really terrible relationships. There can be a lot of tension between these two. This is really where the rubber hits the road in the home. So it's really important as we think about these jobs and what the competencies are behind these jobs. And then, of course, we think about what we pay them and we wonder how we get anybody to do this work. So this is the projection just between 2010 and 2020 of the growth in these jobs. This is where we are expected to see the tremendous growth. It isn't actually in nurses, it's not in the docs, it's not in the therapists in these positions, it's actually in the direct care workforce. Personal care aides and home health aides have the greatest expected growth, about 70%. Nursing aides, orderlies, and attendants, much smaller than that. And all direct care workers, it's about 48%. And that's compared to all occupations in the country, which is only 14%. There is tremendous growth in this sector, and particularly in these jobs, just over the next 10 years. And that actually is when we start to really see the 85 and over population escalate astronomically. So we've got about 10 years really to plan, 6 or 7 years to really plan before we really see the demand grow exponentially. So the characteristics of these folks. They're largely non-Hispanic, middle-aged women. So if that was sort of if you thought about an average home care worker, that's who that is. About half of them are white, about 35% of them are black. Now you might say, well, that's not what my home care agency looks like. Remember, we're talking about the entire United States. One of the things I will say is that that's going to change. We are already expecting over the next 20, 25 years that we're going to see a lot more diversity in the home care workforce. We will also see much more diversity in the elderly population. Right now, it's about 80% white. Within the next 20 years, it will be only 2/3 white, 1/3 of the elderly population will be non-white. Biggest growth in that population is Hispanic. So start to think about the cultural competence issues and all of the things that we need to be really prepared for in terms of a diverse workforce caring for even a more diverse elderly population. Very low wages, and these have been stagnant over 10 years. There's actually been a modest increase in pay in wages for certified nursing assistants in nursing homes. We have not seen that in home care at all. Wages have been completely stagnant. There is great variability in the access to benefits, but relative to their peers in other parts of the healthcare sector, like the nursing home sector and the hospital sector, these folks are much less likely to have access to benefits. Part of that is a lot of them are part-time. Some of that is by choice. Often it is not. This is one of the major concerns right now among the frontline worker population, and that is they cannot get the work that they want. So many of them are working part-time. They have no access to benefits. By the way, I heard this morning there was, I think Doug made a reference to the mandated overtime that has now been delayed. As of yesterday, there were a couple of articles, one in the Wall Street Journal, another in the New York Times. This has been delayed because Medicaid is finally realizing that with these changes, it's going to have a cost to them. And I think it's got to be a wake-up call to everybody that our reimbursement system is predicated on what we pay our front line, because that's where most of those dollars are in the Medicaid program. Those are for labor costs. And that's our labor. It's not our nurses, it's not our docs, it's not our therapists, it's the front line. So this is going to be a real issue because I have no idea how long this is going to be delayed, but Obama just delayed it indefinitely. So the other thing that we found in some research that we have done with the National Home Health Agency Survey and the National Home Health Aid Survey, unfortunately these data are from 2007. These are the only data that are available at the national level. Hospice aides tend to fare much better than any of the other categories of home care aides. They have higher wages, 32% higher than home care and 8% higher than home health aides. They're more likely to have access to health insurance coverage. They're more likely to receive benefits, including paid sick leave, pension, and travel reimbursement. They're more likely to be employed full-time, and they're less likely to quit. So to me, there's a couple messages there. We're not exactly sure the reasons behind this, but the reimbursement rate for hospice is much better, and that may be passed on to the hospice worker. In addition, they tend to get somewhat better training. and it's an environment that is valued. Of all of these sectors within home care, hospice is actually the most valued. So I think it is a message for all of us who are in the home care industry. We need to be thinking about at least how do we start to bring the rest of the direct care workforce in home care at least up to where the hospice workers are now. Whoops. Training requirements, this is, people always say to me, well, my dog groomer has more training hours than my home care worker. I'm not much on hours because hours is a big black box. I really want to know what's going on inside the training, but it is kind of a travesty that for Medicare and Medicaid certified home health, and this should not be Hispanic, this is home health aides, there are federally mandated 75 hours and a competency exam. So that is for home health aides and for hospice aides, 75 hours and a competency exam. For home care and personal care, there's absolutely no federal requirements at all. It varies tremendously by state. Many states do not have any requirements whatsoever. So a home care aide or a personal care aide, or if your mother is just hiring somebody off the street, you can come in with absolutely no training whatsoever. And then with consumer direction, and I know Henry's going to speak to this more, I am very ambivalent about this. I happen to be one of the early promoters of consumer direction and actually was able to get cash and counseling started in 3 states when I was in HHS in the 90s. But I have seen over time that consumer direction can lead to some real issues around lack of training of the workforce. And I believe it is very important for this workforce to be trained because they are in the home, they are the eyes and ears of this system, and they are the first people who actually see a change in condition. Barb Bowers, who's in the School of Nursing at the University of Wisconsin, did a study in which she found that a home health aide picks up a change in condition 5 days before a nurse does. So they are really seeing what's going on in the home as well as in the nursing home, by the way. So training is a serious concern. So the implications right now for employers and consumers really is that we have a lack of competent staff. We often don't have a lack of bodies, and that's been one of the things that's really interesting because a lot of what drives the availability of this workforce is the local economy. So when the economy is not good, we don't have a lot of problems. I work in an organization, LeadingAge. We have about 6,000 nonprofit aging services providers. We have the nursing homes, we have assisted living, we have home care agencies, we have CCRCs, we have low-income housing. Nobody makes a peep when the economy is bad because they're not losing their workers. As soon as the economy picks up, they start seeing this, and we see it. We have already seen change in turnover even in the past few years. So the economy drives the warm body issue. The difference here is that we can no longer be happy with warm bodies, and I tell this to all of my providers in LeadingAge. We're looking for competent workers, people who are trained, people who are skilled. If I need somebody for my mother, I don't want to hire somebody off the street who doesn't know what to do at all, particularly if my mother has cognitive impairment. Dementia is a really scary thing. And think about a home care aide or a home health aide going into somebody's home without any training whatsoever. That is often the case in this country. We have high turnover in churning. We have a lack of consistency in care. Oftentimes, in home care in particular, you don't have consistent assignment. You have people who come and go. This lack of consistency has a lot of implications for both the physical and the mental well-being of the people being cared for. It ends up with heavy workloads for all of the other workers when people call in short or don't show up. It has effects on quality of care and quality of life, although I will tell you that the empirical evidence is not great in this. Nobody has really done the work around it. Nick Castle and a few other folks have actually done work on the implications of CNA turnover for quality of life and quality of care and have seen some significant effects. We assume that the effects will be the same for home care, but we have not empirically tested that. And then it's significantly costly to employers. It's about $400 to $4,500 to replace each home care worker. So if you didn't even care about the workers, but you care about your bottom line. If you look at the turnover rates in home care, which are anywhere between 60 and 75%, these are huge replacement costs for an employer, for an agency, and for the state, who may be the employer for consumer-directed programs. So the factors influencing workforce recruitment and retention, like I said, the local economy. We also have industry stereotyping. Now, this is much worse in the nursing home. Nobody wants to work in a nursing home. But it's also really hard to attract people into home care relative to other parts of the health sector and other jobs. And by the way, that's not just with the frontline workers. We have the same thing with nurses, docs, pharmacy, therapy. It's hard to attract. We don't have parity with the rest of the healthcare system in terms of wages, benefits, the whole 9 yards. So it's a very difficult field to attract and keep. Pay and benefits are a problem, and then working conditions. It is very, very difficult. Home care work is isolating. You don't have an environment like even you have in a nursing home where you've got a cadre of folks to work with. There's no real virtual community other than some of the agencies that I have seen. We have a lot to do to really understand the organization of work in home care. It's one of the areas, if you look at the literature, there's almost nothing on it. But on the face of it, we can understand that it is a difficult and more challenging work environment than where folks are working in the same building or in the same place. And then we think about what are the solutions for this. Well, the first thing is we need competency-based training. We need to have folks who are trained in all of the areas that I just laid out before. They also have to have good clinical placements. Many of these folks have some didactic training, and they might have a dummy that they work on. That's about it. I have sat in many training programs. And then they get thrown in like a wolf, getting thrown in to a community, and they have to sort of fend for themselves. They need better supervision. If there's one thing that is important, it is what is the role of primarily the nurse supervisor, who typically is supervising these workers. The supervision is poor. It is not focused on coaching and mentoring. We have paid very little attention to supervision in home care. Most of the work that has been done in the hospital setting and in nursing homes. But it's actually even more important here because these people are going out by themselves. I've asked people, I've asked consumers of home care, what happens when you have a problem with your aide? Or I've asked an aide, what happens when you have a problem with the person you're caring for? What do you do? They often do not know what to do. And this is the kind of situation we are in right now, particularly with the evolution of a whole different range of home care organizations. We've got franchises. We've got home health agencies. We've got other private duty organizations. Every day, the growth in this business is tremendous, and there's almost no focus on the development of staff whatsoever. We needed career advancement, and that does not just mean ladders. Not every home care aide or personal care attendant wants to be a nurse. And I know there's probably some nurses in the room who might be a little bit offended at that, but quite honestly, many of them want to do this work because this is what they like to do. They need advancement. They need to become dementia specialists. They need to become medication aides. There's a lot of room for advancement in these direct care worker jobs, and we need to be much more creative. We also have to think about how we get worker empowerment. I noticed that we always talk about the team, but I never see the worker in that team. Never have I seen it. I know Peter and George, you always put your worker in the team when I see your PowerPoints. But for the most part, that frontline worker is never in the team. And they are basically the foundation of the team, quite honestly. I know, I'm in a lot of homes. We do research in these areas. So worker empowerment means that they are part and parcel of the team. They are part of care planning. They are part of care implementation. They are part of care change. And then we have to pay attention to wages and benefits. It is a travesty that many of these workers are working for less than a minimum wage, and a number of them are on Medicaid to get their health coverage when they're caring for people who may not be on Medicaid. So the special issues for training this home care workforce is really understanding the multiple comorbidities and the multiple meds. You may not think so because they can't actually assess, but they are doing informal assessment all the time. They are the ones who see functional decline. They are the ones who see depression and social isolation. They are the ones who see and can understand dementia. I recently went to, Peter Rabins did a fabulous talk on dementia, and all I could think of was he ought to be out there training home care aides all over the country, because this was not rocket science. This is skills and knowledge that everybody needs. There is significant family involvement, so these workers need to understand family dynamics, and they need to understand cultural competence. And cultural competence goes a lot beyond language. It goes beyond how do you look at somebody else? How do you touch them? What do they think about pain? How do they think about dementia? How does the family think about dementia? You know, people from many Hispanic backgrounds, we've worked a lot with Chinese folks in Northern California. For them, dementia isn't even a word. It's not even a concept. These frontline workers who are going into these people's homes, they need to understand this. They need to be trained. Just to give you a few examples, there are 3 that I think are really the best out there right now. The one is we're doing an evaluation of something called the PCAST program, which is the personal home care, personal care aid program. It's 5-6 state demonstrations funded through the ACA. North Carolina's program is really the best. It's a 4-phase program that actually develops career lattices and career ladders. They are very much involved with all of the high schools in North Carolina, and they have gotten this program integrated into the community colleges, as well as establishing a certification for these different levels. So this is one program that I would think about emulating. The Elder Care Workforce Alliance's Advanced Direct Care Worker concept, which again thinks about a career lattice, not necessarily becoming a nurse, an RN, but actually becoming a more advanced home care and personal care aide. And probably the best of the statewide programs is the Washington State Home Care and Personal Care Worker Apprenticeship Program, which is formally acknowledged by the Department of Labor. It is an SEIU program, and I will tell you that the union in this situation has done one of the best jobs because they invest in the training in this workforce. This doesn't happen magically. So the long-term trends, we're going to have an emerging care gap. It is really clear. I just finished writing a chapter on the future of family caregiving. Unless we have some major changes in this country, we are looking at a decline in the availability of informal care. We're also looking at a decline in the availability of people who would be in the age groups that would want to be in these jobs, which means that we have to do a much better job of retention. We're also shifting more and more from institutional to home and community-based settings, so the demand is going to increase. And again, I already talked about more ethnically and racially diverse older adults, more highly educated and more demanding older adults as well. Greater disparity between the haves and the have-nots. We've talked a lot about public funding, and public funding drives a lot of home care, but there's also a lot of private sector home care that is going on. And we need to understand what that is. We need to understand who's doing it, and we need to understand whether the workforce is qualified. You know, in Japan, the major business that has gotten into home care is book publishing. They went from a book publishing company to home care companies. Now, the fact is, in Japan, they actually train their workers. But here, where we have temp agencies that have gone into home care, how well are these people being trained? And do we care, particularly if it's in the private market where we don't have the same kind of leverage that we have with the public market? And then I would say the impact of new technologies. I'm sort of a Luddite. I don't see the robots running around anytime soon. I think we will, for the foreseeable future, still see a significant human capital need with technologies that may complement that, but this direct care workforce is sort of here to stay. We need a new pipeline. We need high school students. We need older workers. We need to think about how we redeploy unemployed workers like the Ethan Allen Furniture Store did in the Northeast. They actually did a full retraining program and turned a lot of these folks who wanted to be home care and CNA workers. Former family caregivers. In California, a fifth of the consumer-directed workers who were paid in the IHS program decided that they wanted to stay in home care, and they are now paid workers for others and not their family members. And then finally, technology to help reduce the demand. Strengthening the incumbent workforce, expanding the pool, creating competitive positions, and improving the working conditions, the quality of the job. So I will conclude with one thing, and that is I am on a bandwagon for workforce. All of these fabulous models that you heard, all of these interdisciplinary teams, they don't happen magically. We've got some of the best people in the country right here in this room who do this work. Most people don't have a clue about how to work in an interdisciplinary team, and they don't understand how to do home health or home care. It's not going to happen magically if we don't invest in the workforce, so thanks.